That'd be a good idea.
I hear your voice. I get guilty. Oh, Albert. Hello, Albert.
He's combing his hair for us.
I know. Well, I better I've got to sort my lights out here.
Can't hear you, Albert.
Oh, hi, it's Al. I just came on.
Oh, there you go. Now we hear you.
Okay.
Are you on the phone too, Albert?
Yeah, I'm just on the phone. Rick shamed me into just giving up my aspiration of being able to get a video hookup as well, and just do the phone. So at least I get to talk to you guys.
Oh, good to see you again.
Yeah, it's been a long time. Is this John?
This is Jake.
Oh, okay. So John and I had a talk a while back, and I really admire what the group is doing. I just haven't been able to to get involved with it. This is my kind of first step. So I'd like to keep more involved with what you guys are doing and learn from you and be able to contribute what I can where I can.
Who is it that we're talking to there?
Yeah, I think we have it wrong, or I have it wrong.
Yeah.
Who was just talking?
My name's Al Fott.
Oh, Al, how are you, Al Fott? Yes,
Is that John?
I did shame you.
How do you
Yes.
spell your last name?
P-F-A-D-T.
Yes.
Ooh. Somebody either got mowed over by a truck or a snowstorm went through their house. I know it depends where they live, I suppose. So let's see. Who do we?
I believe it's Daniel.
Let me make some notes here. Al and Albert Villacillo. And who else do we have on? Paul, I've got. We've got a couple of no-name people. We're waiting for names. That's okay. All right. We'll just, anybody else who's hasn't introduced themselves, who's maybe here on the phone, that would like to tell us who they are?
Charlie's. Okay.
Go ahead, Charlie.
Yeah, Charlie Smith.
Charlie Smith. Welcome, Charlie Smith. I think you are a new name.
Yes. C. Christopher is my screen name.
Ah, C. Christopher.
I don't know which one of these colors I am. So.
Okay. So we will welcome. Did you find us through Inspire?
Yes, I was on the call once before, a couple weeks ago.
On the advanced call or on the low risk call?
I think it was this one, the advanced call. Intermediate and advanced.
Low and intermediate is one, and then ours is the advanced. I just don't remember speaking to you.
Yeah.
That could be me. It's quite likely that it could be me. Who else is on the? Who else do we have on the call? Anyone else who hasn't said hello?
Yeah, Rick. This is Albert. I'm on the phone for some reason. Like last time, I can't get through voice.
Really?
On the webcam here.
Oh.
So I'm using the phone instead.
Okay, we see you fine, and we know that you're number 4. Did you get that, Jake?
Yes, I did. I had him down before, and then it turned out it was Al Fott.
There you go. We got too many hours on the call today.
Yeah.
Yeah, it's interesting because Albert, the little sign, there is no microphone for whatever reason. The GoToMeeting is not picking up your sound or volume.
Huh.
Sound and it's not picking up your sound. There is a little box somewhere. I don't remember where it is. Yeah, at the bottom of the that we're getting an awful lot of noise, I think, from you, Charlie. If you could mute for us just for a second.
Okay.
There you go. I've muted you. You're welcome to come back on in a second, but we were just getting an awful lot of sound. Albert, on the
Yes.
little panel, the GoToMeeting panel,
Right.
at the very bottom in the gray area, there's a little cog, a little wheel, a cog. If you click on that, it brings up settings.
Yeah. See, I don't have that little pad.
You don't see the cog right at the bottom of the little GoToMeeting panel?
No, I have this session has been recorded and meeting ID.
And oh, that's interesting because there to the right of that there should be a little cog on the same level.
Yeah, that's.
Yeah.
I forget what I had to do last time, and it was a stupid thing, and then I found it.
Okay. Well, you can always call the GoToMeeting folks, and they'll help you. They're pretty nice, and most of them are pretty knowledgeable, and so we can definitely they can definitely help you out. If you go to the website and tell them you're a user and you're having this issue, they'll help you figure it out.
Okay.
So let me see who I've got. So I have, here are the names that I have. And so if I've missed anybody, you'll tell me. I've got Jake, Paul Frieda, Marty Rodder, Al Fart, Albert Biasio, Charlie Smith, Eric Bookbinder. Who have I missed?
Dan Shoelist.
Sorry, who was that? Oh, Dan Shoelist. Okay. And Dan, have you joined us before?
Yeah, I was on a couple months ago.
Okay. Anyone else that I've missed? Okay. All right, so let's get going. I'm just going to ask you all to mute if you're not speaking. Okay, I'm gonna mute Paul Frieda there because he's obviously he can't hear us. But if you mute whilst you're not speaking, it just helps us, and then I know that, and I'll give you time if we call on you to get yourself squared away. We have a couple of people who are sort of new, and so we'll give them some time to introduce themselves. And then after we've gone through that, I'll go down everybody that's on the call and see who needs some time to speak. I know Marty Rodder does because he sent me a little note. I know Albert does because we've been going back and forth on some issues relating to his genome sequencing. But let's get cracking right now. Charlie, if you are comfortable enough doing this, perhaps you can just give us a little bit of background on your disease and how we can help you. I don't know. That was somebody that just maybe somebody just joined us. Oh, Jeff Ledoux's on as well with us now, I see. Just before we kick off with Charlie, anybody else that's just joined us?
This is Eric. I joined, and that's what caused the feedback. Sorry about that.
Okay. All right.
I'm on both computer and phone.
Okay. So we know. So Eric's also number 5 on the phones there, Jake.
Okay.
So Charlie, tell us a little bit about your situation, if you don't mind. Are you with us, Charlie?
Jeff finally made it.
Well, it sounds like Charlie is not with us right now, so let's go to Al Fat, who isn't really new because we've met at PCRI in the past, and he's been on the call a couple of times, but it's an awful long time since you've been on the call, Al. So why don't you tell the guys a little bit about your background and, just bring us up to date.
Me or a different Albert?
No, Al Fat, are you there?
Okay, now I'm sorry. I took myself off mute. I was on mute there, so you couldn't hear me. So
Okay. Yeah, go ahead.
So, there's a saying in the medical community that it's as important to know what person the disease has as what disease the person has. And my Gleason 9 cancer was diagnosed about 2.5 years ago, but it took on a research scientist. So I've been studying this sucker for 2.5 years using whatever techniques I have at my disposal as a single subject researcher. And I think I figured out a way to kind of track, PSA variability and changes in variability over time. And I've documented 2 failures of curative treatments, both surgery and salvage radiation. My PSA kinetics go right back to what they were even before treatment. So this cancer is on its own course, and I haven't deviated using this graphic, representational method. I haven't deviated from its course in the last 2.5 years, no matter what I've thrown at it. Except recently, I started a trial with Casodex, 150 milligrams to block the testosterone reuptake. And that really dramatically dropped the PSA down to the lowest it's been in 2 years. It's like 5.5. But I don't have a prostate, so that's still something that's producing a lot of PSA in the system there. That's probably not a good sign. But it's only been a month, so we'll see how far it goes down and what I can do in addition to that. And trying to stay healthy and optimistic at the same time is really looking at my treatment options dwindling. And the most recent PET scan I had, the Oxyman enhanced PET scan, where these smaller regions light up, is some areas finally lit up that never showed up in scans before. They're in my bones. It's obvious my cancer is metastasized somewhere. That it's continuing to grow despite surgery and radiation. So now we can see it in these little spots. So that's sort of like an easy feeling to actually see the cancer that way, and to realize it's a physical dimension that spreads, and you can see it. So now you can actually see that. You don't have to have a secondary measure, and that's where I am.
How high did your PSA get when your cancer first recurred after surgery?
Not really. When it was diagnosed, it had gone up from 8 to 10 in the 1 month period from my digital rectal examination to the confirmation of the diagnosis. So it was growing pretty aggressively, during that period. But I think it started fairly early. So I think actually I can tell it started actually growing at a cancerous rate. My PSAs started growing at a cancerous rate about 18 months before I was diagnosed. And you can sort of see that from the graph retrospectively. You see, like, okay, that's probably when it started. That makes sense. And the progression line you get when you draw those points and put them together, it all fits on the same path. And the outcome is that this cancer is going to get to where it got no matter what I did. And that was true. It got to the same outcome on that trajectory after the surgery, after the radiation, after medical marijuana, after all this spitting and coughing and carrying on, it ends up where it's going to be anyway. So I think that's what we're dealing with. And me, in my case anyway, is a cancer that has that sort of characteristic signature. That when it's growing, you can see it's growing at its rate. I mean, this is its preferred rate. This is how it grows. And you can see it. Visually, you can represent it. And I think that's important. Once you can do that with your cancer, once you can see it and understand its particular growth pattern, then that's your own baseline to evaluate your own treatment. You don't need to be in a trial with a group of other people and have a group average and all that sort of stuff. You just evaluate your own performance over time.
What has been your PSA pattern between the time that your cancer started to recur and the time you started taking the high-dose Casedex?
It got up to 62.
62?
62, yes. 62, yes.
Okay.
And it was progression the same pathway. It was just, it just grows at doubling time about 3 months if you want to translate it into doubling time. It's just growing very aggressively, but it's still fairly small because I think we caught it early and, knocking out the prostate and the prostate bed. I think any residual cancer is still at an early stage of growth. It's just getting a foothold. That's my self-diagnosis. It's obviously systemic in the sense that it's multiple locations and it's going to need some kind of systemic treatment. Medical marijuana did that for 4 months a year and a half ago, and I'm going to try that again now to see together with the Casedex if the medical marijuana and the Casedex could work in concert to cut off that food supply. Blocking the testosterone channel and also the CBD receptors and the THC receptors for the cannabis.
I'm sure you know that at least I've never seen any evidence that medical marijuana has any curative effect. It certainly has a palliative effect, and it certainly has its uses. But
well, if you believe Terry Hills, Dennis Hill is the person. Now, he doesn't have really hard evidence. He says he was diagnosed at stage 4 prostate cancer. You don't see his biopsies, or you don't see the MRIs, or whatever.
No, I mean, he doesn't tell you much, Alan. And what I'm not really.
No, I agree. I agree entirely.
Talking about anecdotal. I mean, what I was going to say is, if it works for you and it seems to have worked, then by all means. But we don't have any anecdotal information that it works to help manage the disease from spreading. We have plenty of evidence that it helps in many different palliative ways. So what is interesting is that you say that you got up to a high of 62, and then was that right before you started taking your high-dose Casedex, or?
Yes, exactly. And within a month, it's gone from 62 to 5.5.
Okay, so you really responded well to that, huh?
It's the same rate of response the whole way through, yes. I'd say that's a powerful response.
Yeah.
And it's every reason to suspect it's continuing. So the next data point I'll get, I was going to wait until the end of the month, rather than have it, because already my doctor thinks I'm a nut for wanting it at all. And, you know, I said to them, well, I'd like to have it every 2 weeks. Oh, come on, you're such a pain in the ass. You know, I said, okay, so I'll settle for a month. So I'll wait for a month and get another reading and see if it continues on the same projection. But now you can draw a line of projection, and you can say, so if it continues at the same rate, next month it should be at, and you can predict the level where it would be if that rate continued.
Yeah, but I mean,
so that becomes the scientific hypothesis.
I understand, but to come from 62 down to 5.5 in a month, is that right?
Yes. Yes.
I mean, you know, that's a much faster rate than it was increasing, correct?
It's a fairly similar rate, actually. If you look at it, you know, in an inverse mirror, yeah, the rates they mirror each other.
Well, I don't really get that, because if you were doubling every 3 months, which is what you told me, and you've gone from 62 down to 5.5 in a month, the slope of that curve has got to be a lot steeper coming down than it was going up.
That's a good point. Yeah, no, but you're only dealing with 2 points. That's the problem with any point-to-point comparison. You really have to have 3 points before you can make any meaningful comparisons.
Well, that's right.
With the PSA variability being what it is.
That's
but
right.
You're right.
But
you know, just on the basis of those 2 points, you would say, right, that's a much steeper.
Right, and even if we pushed you out a month and you went to 0, God willing, in the next month, it'd still be a lot steeper, because it can't go below 0. So, you know,
Exactly.
You know, now, if you stayed at 5.5 for the next 3 or 4 months or 5 months, maybe we start to see something similar. But where are you being treated, Al? I forget.
NYU Langone. My oncologist, I'm sort of like his patient from hell. I come in with a graph. I come in with the latest research. He's very patronizing. Oh, there, Mr. Fott, you know, that's okay. You don't understand, you know. So fortunately, my wife is with me to mediate the discussion. She does a good job.
Okay.
And we've actually gotten to the point where, you know, he called me on vacation and told me he wanted to start the, you know, he wants me to start Lupron. You know, I'm trying to delay the onset of the Lupron with the Casodex, and then whatever else I might add on top of that before I used to. That's just for my own peace of mind. By the way, that's not based on any evidence, you know, except what you hear from people. But I'd rather have the Lupron, you know, be the next step after the Casodex doesn't work.
So, do you have anything you'd like to raise with the group, or otherwise I'm going to open it up and let the guys talk to you, because they may have some questions.
Oh, please. Yeah, by all means.
Well, is there anything you'd like to raise before I do that?
No, I mean, I may sound like, oh, I've got this all together. It's a very anxiety-provoking time for me right now. I mean, I failed 2 major curative attempts. I'm facing, you know, a downhill, you know, struggle that's, you know, going to get worse in terms of side effects. And okay, I can deal with that, but I'd rather prolong the period of good health that I have right now, because I'm not symptomatic through any of this. The only symptoms I have are side effects from the treatments, as far as I can tell.
Right. One thing that we should mention to you is that from a non-treatment standpoint, we run a group called the Inner Conversation. And that group really addresses the emotional difficulties that men may have in dealing with their diagnosis, with their side effects, with their progression, with the disease. And since Jake is one of the moderators, Jake, why don't you give a quick commercial for that group, and tell Al, if you'd like, how he can do that.
Okay. Hi, Al. This is Jake.
Hey, Jake. Hi.
We meet. Hi. The Inner Conversations group meets every the second and third Thursday of the month. The next one will be next Thursday. Excuse me, at 8 o'clock. It's not to talk about technical stuff. To just basically we talk about how do you feelings. How do you feel about what's going on? How is it affecting you? How is it affecting you? How is it affecting your family life? We a lot of times we end up telling jokes and just kind of just BSing, and
Sure.
we usually we don't solve any problems, but we end up laughing and feeling good after the meeting's over. So.
Oh, that's important.
Yeah. So it's a good thing. It's a good thing to have. It's just another tool in your arsenal. But I would strongly recommend you join us. The next one will be next Thursday. I think is the 23rd, I believe. I'm not quite sure of the date, but not this coming Thursday, but next Thursday.
Got you right.
8 o'clock.
And it's the same call-in number?
Yes.
Exactly. Yeah.
Yep. Same number.
Okay, cool.
Same everything.
Yeah.
Excellent. Good.
We'll see you there.
And that's what time? 6 o'clock. Is it 6 o'clock Eastern Standard Time again?
8 o'clock.
8 o'clock?
8 o'clock. That
it's
one.
8 o'clock Eastern.
Yeah. 8 o'clock.
You're in New York, you said?
Yes.
You say you're in New York?
Yes.
Yeah, so it'll be 8 o'clock.
Okay, excellent. Okay, cool. So,
guys, would anybody like to talk to Al about his treatment, his pattern, his decision to go with high-dose Casedex before moving to Lupron, or anything that he might have thought about? I'll throw it open.
Well, this is Jake again. Al, you said that your PET scan showed a lot of spots in your bones. So obviously.
Yeah, the oxygen. Yeah, it's. I showed it to some people. I was down at the PIA conference in Florida, and I had a couple people take a look at the results of the scan, or the report. That the results of the scan. You said that would be a whole different thing, but it picks up small things that weren't seen before that light up. This very likely cancerous along the spine. Although I've had periods of activity before in PET scans where people were wondering, for old scans, oh, was that the cancer back then? So I've got osteoarthritis of the bones, and we got a lot of stuff going on. So there's a lot of noise in the background.
So your doctor can't determine whether it's cancer or not, for sure?
I think the feeling was that this is pretty likely cancerous. Yes, it's there's small diffuse masses, like a big primary tumor lurking anywhere. So it seems like that. And you sort of know that on the basis of the PSA rise, but it hasn't shown up in any of the conventional scans before, the bone scans, the CAT scans of the abdomen, with enhancement, where they haven't picked up any location.
Well,
so this is the first time that there's this.
I would suggest you ask your doctor if it's only a few spots. Maybe you'd be eligible for radiation to your spine.
Well, this is what I was interested in. I didn't get a very good response.
They don't like to do a lot. Well, then you might want to find another doctor or get a second opinion.
I think so. Yes.
I would also think that in the future you're going to be having Lupron. If it's in your bones,
sure. No,
that's a standard treatment.
Yeah. No, it's and whether postponing the inevitable is a good thing or not for me at this time, I don't know, but I want to try and enjoy my good health as much as I can, relative good health, with all the side effects and everything. I had a urinary sphincter implant that really improved the quality of my life better than anything that I've experienced along the way so far. And that at least got me out of the diapers and into moderate shields and feeling comfortable at the beach and stuff like that, where I didn't have that before. So that was really, I want to enjoy that as long as I can.
Well, feeling good about yourself is certainly important. There's no doubt about that. Anyway, that's my 2 cents. I would, if your doctor poo-poos, if he won't give you a good answer on the possibility of radiation, if there's only a few spots, then you should talk to another doctor. This would be my suggestion.
Yeah, I think. Yeah, I'm with you on that. I think that's. Yep. Thank you.
Sure, you're welcome.
All right, well, unless anybody else would like to talk to Al about anything in particular, I'm going to move along because we've got a couple of people that have either new or they've come back after procedures. So in the interest of time, I want to keep pushing along. I think probably next we should let's talk with Dan Shoelist. And Dan, forgive me, I do remember now. Of course, all of the conversations we had, and that you were on the call. And I think you had a procedure at Mayo. Is that right?
Yeah, actually I did not. I chose a different route than Mayo.
Okay, well, fill us in a little bit on what your background, you could tell us a little bit about your disease, because I know it, but the rest of the guys may not. And
Sure.
And tell us what you are doing.
All right. So I was diagnosed in May of 2016. I'm 51 years old. I had a PSA of 120 and Gleason 9 in 10 of 12 cores. I was looking at surgery at Mayo Clinic, and I was scheduled to have that done in December. But I didn't finally get to meet with the surgeon until November. And after having a conversation with the surgeon, it was a little bit sobering as to what the outcome was probably going to be. And about that time, I discovered a Dr. Gary Onek in Florida, who treats prostate cancer with cryoablation and immunotherapy. And so after investigating him and meeting with him and talking to him several times, I was treated by him a couple of weeks ago. Mm-hmm. And I'm now waiting to monitor my PSA. I was on, I did get a shot of, oh, doggone, I can't remember anymore. Firmagon. Mm-hmm. Initially got a shot of Firmagon, then right away I got a shot of Firmagon. Then like 60 days later I got a shot of Lupron. Mm-hmm. And then 45 days later they put me on Casadix. And my PSA was down to under 0.1. So I had a good response. I do have lymph node involvement according to the scans, but no bone involvement. I did have a, I also had a PSMA scan done in Houston back in January, but it didn't show much, but it was, my PSA was at less than 0.1 at that time, so I wasn't
you
expecting
mentioned immunotherapy, Dan. What type of immunotherapy is Dr. Onek talking about?
He's using Cativa or Keytruda, Yervoy, and Optivo. He uses all three.
And how does he decide what to give you and when to give it to you?
Well, that's a good question. He's, I don't know how exactly he came up with how much. He doesn't administer it systemically like they recommend it. He does it. He injects it directly into the prostate.
He injects it directly into the prostate. Wow.
Yes.
And how is that supposed to help? Or how does he tell you that will help the disease that is evident in the lymph glands?
Well, theoretically, if your body will have an immune response
Mm-hmm.
to the cancer cells.
Mm-hmm. Mm-hmm. Mm-hmm.
There's another doctor who's also doing this quite successfully. His name is Jason Williams, and you can YouTube. He's got some YouTube videos out that you can watch.
Right.
He's doing it. He doesn't do strictly prostate cancer. He does other cancers, but he does do prostate cancer. And he has a office in Alabama, I think, and treats in out of Mexico.
What has been what's Dr. Onick's track record been in helping men that have locally advanced prostate cancer, where he treats them with cryoablation and immunotherapy?
So he doesn't have any, I mean, he hasn't documented or, formally reported on it, but I did talk to several patients
Mm-hmm.
Who were treated by him, some from around the world who were treated by him.
Mm-hmm. Mm-hmm.
Successfully. But it's not long term. He's only been doing it for, I think the first patient he treated this way was 18 months ago.
Right.
He doesn't have a long term, but he's got a 10-year. He's got a he does have a documented study on just treating with cryotherapy.
Right.
That you could look at. He's got 10-year
Right.
10-year results.
Right.
That are pretty impressive.
Right.
And
I would. We have someone on the phone in the group right now who has a lot of expertise in this area, and I'm wondering if you would mind if I asked him for his opinion on the effectiveness. But I want to ask you first, because I don't want you to hear anything you don't want to hear.
yeah, sure.
Professor Bill, I see your name. Are you with us or are you not with us? I'm not sure. Oh, wait, yes.
Rick.
Hi,
Yes,
Bill.
I'm here.
And have you been listening to Dr. Onick's protocol?
No, I'm sorry. I missed the discussion. I'm just returning.
Okay.
Can you just fill me in quickly?
I can fill you in. So, Dan Schulist is a young man, 51 years old, lives in Milwaukee. He had a small amount of Gleason 9 cancer. His PSA was pretty high, 120. And I shouldn't say a small amount. He had a fair amount of Gleason 9 cancer. 12, as I recall, 12 out of 12 were positive. Is that right, Dan?
It was 10 out of 12. Actually.
10 out of 12 were positive.
Okay. Yep.
And there was also evidence of that it had reached the local lymph nodes. And Dan had been talking to Mayo. Mayo wanted to do surgery back at the end of the year, and Dan decided to go down to see Gary Onick in Florida, who does cryoablation, and it's a focal treatment, or more of a focal treatment. and he supplements that with immunotherapy. And Dan just explained to us that the immunotherapy that Onik uses is one of either Keytruda, Yervoy, or Opdivo, which he injects into the prostate. And
Okay.
and my understanding from what Dan just said is that the hope is that this will stimulate the immune system, sensitize it to the prostate cells, and so the immune system will then respond and attack the prostate cells that have escaped from the prostate. And I just asked Dan, would he mind if we spoke to you and asked you about your opinion on that? And I should tell Dan that Professor Bill Burhans is a professor and a cancer researcher and leads a lab at Roswell Park, which is an NCCN facility, and has been looking at mutations in genes that lead to cancer for many years. He's also a patient, and he's had a lot of success with aliparab, which is another immune agent. So he sees this puzzle from more than one side. And I'm just curious whether you've heard of anybody doing anything like this and what your take from a scientist's view would be of something like that, Bill.
Well, no, I haven't heard of anyone directly injecting it into the prostate tumor, and it's hard to imagine how that could help in a systemic way if you know, there's some metastases to the lymph nodes. Is that correct? Did I catch that correctly?
Yep.
Yep.
Yeah. So it doesn't. Well, first of all, I should qualify what I'm going to tell you by telling you that I also telling you that I'm a geneticist and a molecular biologist, and so immunotherapy and anything that has to do with the immune system is not my strong point, but I do know quite a bit, and I've just never heard of this drug being delivered in that way. That doesn't mean that it isn't and that it might not work, but it's I'm curious. It doesn't seem like theoretically it should work that way. Rick, what do you think?
Well, I guess my thought is that if it were possible, and I have no idea if this is possible, Bill, but if it were possible to use one of these anti-PD-1s like Keytruda or Opdivo, and by injecting it into the prostate to also sensitize it to prostate cells, it would make some sense. But I have no idea if by injecting it directly into the prostate that is going to happen. You know, I don't know what the theory is, and that's what I asked Dan before. I mean, what is the theory that injecting it into the prostate is going to help you with disease that's spread beyond the prostate?
Yeah, exactly. That's my concern too. I'm looking for information about how this drug what the recommendation is for delivery of this drug, but I haven't found an answer yet.
Hold on one second, guys.
In any case, I've got to
just keep talking. I've just got to get rid of this call.
Okay. I'm skeptical. It doesn't really make a lot of sense, but give me another few minutes. Maybe you should go on to another caller and if you give me a few more minutes, I might be able to come up with something.
That would be great.
Okay.
Well, Dan, let's just stick with you a little bit longer and until see if we hear anything from Bill. But do you have any questions for us? And how are you feeling? Where's your PSA right now? Did you say you haven't tested since the cryoablation, so you're not sure?
No, I'll get tested in 2 weeks.
Okay, but you responded really well to the hormone therapy.
Yes.
And you came down to, did you say to less than 0.1?
Yes.
Well, that's really great. And does Dr. Onik plan to keep you on the hormone therapy for any period of time, or what's the plan for hormone therapy for you?
No, I'm off of it. I went off of it a week before the treatment.
Okay. Okay.
So Dan and Rick, I've dug out some information, and the recommended way to administer this drug is intravenously. So which is what I thought was the case, and I don't see any indication that it's recommended that it be injected directly into the prostate gland. So I don't know. Dan, I'm sorry, is that your name?
Yes.
Yep.
Yeah. I would ask your doctor, whether or not this is the standard approach for treatment with this.
I know it's not the standard. It's admittedly not the standard.
Dan,
okay. Well, then
standard is to do it intravenously. The problem is it would be $100,000 a treatment.
Right. Right.
And it's not, those drugs are not approved for prostate cancer, so your insurance wouldn't cover it. So nobody would be able to afford it.
Well, that's not strictly true, because now if you have certain gene mutations, you can get the insurance to cover it, but it's probably going to be later in the disease path. And I think it's certainly true at the point where you are in the disease path that it would be a real struggle to get them to approve a treatment protocol. Now, the other thing is that $100,000 covers repeated treatments. I mean, one dose of the Keytruda runs about $9,000-$10,000, somewhere in that range. And I don't know how many times and whether what he's injecting in cannot be anywhere near a dose of Keytruda, because I've actually seen a dose of Keytruda, and there's a lot more than would be injected in. But having said all of that, here's my biggest concern, Dan. And you haven't asked, and so I'm sort of take this for advice is worth what you pay for it. So just bear that in mind. But if I had disease that I knew was out of the box, then I would want to do all I could to kill that disease early on, and to move myself into a place of durable remission as quickly as I could. Cure is probably never going to happen, but durable remission is feasible, and the disease may go dormant for many, many years, may never come back, may spring up pretty quickly. And so I would be looking, whilst I don't have anything against some of these new treatments, they may well work, we don't know, I don't say don't try it. I think I would be wanting to back it up with what we do know works. And to go off of hormone therapy so quickly is a concern. It would be a concern to me. We know that when somebody has high Gleason hormone therapy, and again, what was your Gleason score?
9.
Sorry?
9?
9, yeah, that's what I thought. You know, we know that when you've got a Gleason 9, that you probably need to be on hormone therapy continuously for a good 12 to 18 months at a minimum. And whilst it's very difficult, it's not an easy treatment. We all know, most of us know on this call firsthand how difficult it can be. It can make an enormous difference. And if you wait and the disease gets a hold during that period, you can't roll the clock back. Now, to focus and debulk the tumor, there are some doctors who would say, it's in the lymph nodes, we're not going to do any primary treatment. I think that now when we see lymphatic disease only, that's becoming less and less common, and more doctors are willing to do surgery and followed up with radiation and a longer course. But the focal treatment that you got debulks the tumor. I can see why you would opt not to have radiation across the pelvic girdle, which might be something that could be considered as additional. But I also think that if it were me, I would be submitting myself to a longer period of time with Lupron. And certainly at a young age, you know, we don't want to be talking to you and supporting you. We want to support you as long as we have to support you. But we don't want to be supporting you a year from now in a situation where you're saying, you know what, my PSA has come back high because I haven't been on any hormone therapy. I'm back at 100 again. What should I do? And we've got guys like that. I mean, I think of one guy who several years ago went to Germany and did he did the it wasn't HIFU, but it was something very similar to HIFU, and the disease has come back, and now he's looking at what should he do next and talking about surgery and radiation and what have you. And what we can't do is allow the disease to get a foothold. So, you know, I just want you to consider that. And let me throw it open.
Well, I mean, I appreciate that, Rick. The way I'm looking at it is, you know, I think it's pretty common to go CRPC within 2 years if you stay on Lupron. I don't want to be in that situation. You know, I don't know if you've heard of the Parton tables from Johns Hopkins, but in my situation, if I had surgery, there's a 94% chance the cancer's coming back.
Mm-hmm. Yeah,
so,
but that doesn't mean, but if the cancer comes back, that doesn't mean to say that you're going to go castrate resistant within 2 years. The cancer can come
if I stay
back.
on Lupron, I think there's a pretty good chance I go castrate resistant within 2 years.
Where do you get that from?
I think that's pretty common, and that's what Mayo told me. That's what the surgeon told me at Mayo, Dr. Carnes.
I would beg to differ with that. Let me see who's on our call right now, who's been on Lupron and not yet gone castrate resistant. I don't know if we've got anybody today, but I got a lot of guys. Well, Paul Frieda, I don't know, he mentioned he's got guests, but Paul Frieda has been on Lupron now for a good year and a half. He's still responding. Jake, how long have you been on Lupron, and you're not castrate resistant, are you?
Yeah, I am castrate resistant,
Yeah.
Rick.
How long?
I've been on it since July of 2000. I've been on it since July of 2012.
Right, and how long before you went?
I think probably good 3 years before it actually started going back up again. It kept it in line at 0.5, 0.6, and never got lower than 0.5.
Mm-hmm.
but it kept it at that point for quite a long time, and then gradually started rising.
Mm-hmm.
You know, my comment to the gentleman talking is that if you're going to go castrate resistant on Lupron, you're going to go castrate resistant without it too, and probably faster. And it's going to and it's going to get out of hand. At the very least, the Lupron will keep it in check.
Can you say that again?
Can you repeat that, Jay?
I heard
Yeah,
someone.
I missed that too.
Yeah.
Can you
Yeah.
repeat that?
I heard someone speak.
Yeah, no, that was, I was trying to see if Paul Frieda was on the line, but he hasn't muted, and so I just unmuted him for a second, and it was the background noise.
Okay.
That.
So, Dan, this is Bill Burhan speaking again. I completely understand your that you want to avoid becoming castrate resistant, and I think that what the oncologist that you spoke with at the Mayo was talking about is that if you go on a drug like Lupron, it's going to select for castrate resistance, and therefore it might happen sooner than later. But I think with your parameters, you are going to become castrate resistant. You know, you may delay it a little bit, but not by much, and you're running a huge risk that you're going to have problems that extend far beyond castrate resistance if you don't go on to anti-hormone therapy. So I just think that the approach that your doctor is taking with you is very, very risky.
Is there anyone on the call who has been on Lupron or on an LHRH drug for more than 2 years and who is still responding to the Lupron?
Rick, Jeff here.
Yes,
I
Jeff.
don't know if you. I have been on for almost 2.5 years with the Degarelix,
Right.
and I'm also now on Casodex.
Okay.
So I am considered castration-resistant prostate cancer, but my PSA actually came down just a little bit as of today.
Good.
Not much, but a little bit. But
Okay.
so it's still measurably effective.
Okay. So by adding the Casodex, it started to go up, and then adding the Casodex brought it back down again, right?
Well, the Casodex, it went up even with it. What I did was, at the recommendation of the PA, I added Imodium to keep it from diarrhea and flushing it straight through. So that seems to be helping. That has stopped that side effect. So, you know, there I am.
And what did your PSA come down to?
It came from 2.24 to 2.22. I said it was minimal.
Right.
It was very small.
Yeah, but we should also add, for Dan's benefit, that you're one of these guys that, I mean, you made a lot of PSA in the first place, but since then you haven't. Isn't that right?
That's correct.
Yeah. I don't know, Dan. I mean, you know, I just want to hear all the different sides. I mean, yeah, sooner or later you get castrate resistant. That's how it works. But I think 2 years is, it depends. I mean, you know, maybe with the Gleason 9, that's a fair response. I can't. I don't want to argue with these guys. I mean, I think it is probably a very fair response that maybe with Gleason 9 it could be 2 years. But you know, the name of the game here is to get the most you can out of each phase, whilst at the same time not letting the disease get out of hand. And what concerns me is that ablation with one of those immunoagents injected right into the prostate I don't know how that's going to systemically stop the disease from spreading. And I think you've got to get an answer to that from your doctor and convince that that's going to happen.
Well, I do have an answer. I guess it just depends on whether you believe it, and I guess we'll see what happens. There's cryoablation has been known to create an immune response from the body as well, based on the dead cancer cells that are left behind. So the way I'm looking at this treatment is the only way I have a chance at being cured is if I get my immune system to fight this disease. That's the only chance. And I believe with this treatment, there's two chances at having that happen. One with the cryoablation and one with the immunotherapy. So I'm not, there's certainly no guarantee. I think, I'll be monitoring my PSA regularly. If we're not getting the response that we expect, I will quickly take a different route. But
I would say we all agree with you about your statement about immunotherapy. I mean, if you can wake up your immune system and get the immune system to fight the disease, then that's really going to be the best possible option. I just don't really understand how either the ablation is going to have this sort of abscopal effect that you're talking about, and how injecting these agents into the prostate are going to have the sort of effect that you're hoping for. I hope they do. I
think that this is Bill Burhan speaking.
Yes, go ahead.
Again. I think that, the cryoablation will stimulate the immune system through an abscopal effect by dumping, as cells die, just as Dan said a few minutes ago, by dumping a lot of dead cells into the circulatory system, that, there are going to be a lot of antigens that will be recognized by immune system molecules. That's, part of that process. But I just don't think that this approach to immunotherapy, the injection of this drug directly into the prostate gland, has any hope of helping you very much, Dan. I really don't. And I agree that immunotherapy is a really important and can be a very effective approach. But there are lots of other immunotherapy approaches that you can try. Have you considered Provenge, for example?
No. I mean, what I read about Provenge is it's a failure.
Why would you say?
No, that's not correct.
Why would, hold on.
I think.
Let me just drill down into that. Why would you say that, Dan?
Well, from the results I've seen from people that have been on Provenge, that's not working.
Well, what results are you talking about? Are you talking about just talking?
I'd have to go look, Rick. I mean, I don't have them right now at my disposal, but I've done some research on it.
Right.
And, even Mayo told me Provenge doesn't work.
Yeah, well, so here's the thing with Provenge, and one of the reasons why people say that, because they really haven't looked at the studies. The Provenge was approved by the FDA on the basis that it extended life by about 4 months. But if you look at the population, that was the overall result because there were a lot of men who had very advanced cancer when they got their Provenge. And what we know about Provenge is that when you have a heavy tumor burden, it's not going to work. The principal investigator said to me, this is his analogy. He said, if you don't have a long enough landing strip, it ain't going to work. Now, what we do know is that if you get Provenge when your PSA is less than 20, it can have a pretty significant effect. That's actually what the study said if you look at the study. Do we know how much of an effect? We really don't. I mean, to be honest, if you really want to get the biggest bang for your buck, go for chemo right now, because that's where you're going to get the biggest bang for your buck. But you're also going to have to deal with a lot of significant side effects, or you may do. Everybody's different. Some men handle it well, others don't. But the chemo seems to be the best. If you want to get probably the least amount of side effects, look at Provenge. But what we do know is that the Provenge, which is an immunotherapy drug, works a little differently to most of these other drugs that we've been talking about, like the Opdivo and the Keytruda and the IPI. What we do know is that it probably has a pretty significant effect given to men who take it early enough in the disease cycle. And you obviously are not eligible insurance-wise because you have to wait until you're castrate resistant and you get 3 increases in your PSA. Now, there are people that Mickey Mouse that, so they will wait until they don't respond to the Lupron. They'll get 3 increases in their PSA. They'll get some Provenge, and then they'll go on Casodex or something else, and it'll bring their PSA back down again. You can do that. I know people that have done that. But at the same time, you know, if you're going to spend a lot of money and you have the money available to you, it's probably worth looking at. I mean, it's, you know, it's $100,000 treatment. You can probably get it cheaper as an individual or cash. I don't know. But I wouldn't write off Provenge on the basis that it only added 4 months. That's not reading, that's really not understanding or reading the studies correctly. Look, we're not going to keep beating up on you. I mean, we're doing this because we want you to be sure that you get the best. And clearly, you've moved down this road, and I hope you'll keep coming back. I hope you'll tell us, and it's real interesting to all of us. But I also want you to be sure that you're covering all your bases. And like you say, Dan, if you are monitoring your PSA on a very regular basis, then you're just going to have to make a decision. God forbid it starts to go up from the 0.1 it's been at, then, you know, talk to us when you're ready to intervene and listen to some of the ideas that come out of this call, because there are some good ideas and we have a lot of knowledge on here. At the same time, we really welcome people that try alternative routes.
So Dan, it's Bill Burhans again. I really hope that you do come back and let us know how this works out. You know, it would be a mistake for somebody like me who's sort of in this business to say that the approach you're taking is absolutely wrong. That's not the case, and maybe you will see an effect that would be would be really interesting to me. So, especially if things work out well, I hope you come back and let us know that's the case.
Okay, so we'll move on. Charlie Smith, are you with us?
I'm here. Could you hear me?
We can hear you.
All right.
And again, whoever is not talking, if you can mute, because we're getting a fair amount of background noise. Thanks. Whoever just did that, we thank you. Charlie, tell us about where you're at and in your disease cycle and how we can help you.
Okay. It's almost exactly a year I had my prostate removed at Fox Chase, and over the last year, first 6 months were fine, and then I did the ultra-sensitive PSA, and it went from 0.3 to 0.7 to 1.0 to 1.4. Basically, it's a pretty, I don't know if people tell me doubling time isn't accurate at low levels, but if you did the math, I'm slightly less than 3 months of those numbers keep doubling. So I live up in the Scranton, Pennsylvania area, which is about 2 hours north of Philadelphia. So we agreed that I needed to do radiation, but no one agreed that I needed androgen, hormone therapy in concert with that. So I went and got a couple of opinions, and eventually I was able to convince the radiation oncologist up in the Scranton area that I did need it. They did agree to it. 2 weeks ago I went on Casedex for, I guess, to stop the flare-up, and then this Friday coming I'm planning on getting a Lupron shot. And they're not going to wait the traditional 2 months. They're going to only wait a couple weeks because I don't have a prostate, he said, and my tumor burden's really low. And then I'm going to start radiation therapy, which is actually a tomotherapy. I don't know if anybody's familiar with that, but I guess it's a combination CT scanner and radiation. So that's kind of where I'm at. But a couple of weeks ago I was on this call, and I think it was you guys that convinced me that I needed to, and I saw the studies in the New England Journal of Medicine, and I also did the nomograms on Memorial Sloan Ketterling's, and definitely survival rate or biochemical survival rate does improve significantly with hormone therapy. Now, at the time, I didn't realize what the difference between Casedex and Lupron was and all that. And, the Casedex I've only taken for 2 weeks, which really I can't even tell I take it. I am going to take another PSA test this week just to see if it had any effects. But the Lupron kind of scares me. But I'm 54 years old. My primary, I had a Gleason score of 3+4. My PSA was about 7.4, but I had extracapular extension. The pathology report confirmed that after prostatectomy. But I had no lymph nodes or seminal vesicle invasion, and I also didn't have any surgical margin or positive surgical margins, which, I mean, initially I thought, hey, that's great, but now I kind of think, well, where is this prostate cancer? If you cut it out and there's no positive margins and nothing else is affected, kind of worries me to some degree. So, but anyway, they also agreed to do the whole pelvic bed as opposed to more of just the prostate bed.
Right.
That's kind of where I'm at.
What's the so I'm not familiar with this type of radiation that you're getting. Tell me the name of it again.
Tomotherapy?
Oh, tomotherapy. Okay. Yeah. Yeah. I know very little about it. I don't know.
Yeah, there's only, like, if you're in Australia, there's one machine, and there's not a lot in the United States. It's not stereotactic, but it's still IMRT.
Okay.
But they're looking at it's more supposedly more accurate. I don't know if it's any better or the outcome's any better, but some people say it is. They could supposedly give you higher doses without damaging your rectum and bladder and other organs.
Mm-hmm. Mm-hmm. Yeah, I mean, forgive me again. I do recall our conversation with you now, and I think it is smart. I mean, you've heard the situation with Dan, and I think that your follow-up makes a lot of sense. I'm going to post in the window, in the chat window for you, a a link to a hormone therapy pamphlet that is produced at UCSF, and which I had a hand in writing the first draft of 4 or 5 years ago. It's a little out of date in terms of the newer hormone therapies, which isn't going to bother you that much, but it will give you a pretty good feel for the extent of hormone therapy, the type of side effects and comorbidities that you can expect, and it'll give you some little tips on how you can combat some of this stuff. For example, one of the issues with hormone therapy that a lot of people don't really recognize is they're hungry all the time. And the reason is because it slows your metabolism. And people complain about putting weight on. Well, one of the reasons they put weight on is because they actually are eating more and they don't realize they're eating more. So, one of the little things that you can do is, you keep carrots and celery and cucumber and stuff like that around, and you get hungry, you snack on that rather than snacking on fattening foods. So read the pamphlet. It comes from a very good, highly respected organization, institution, a center of excellence, one of the best prostate cancer groups in the country. And, it may well answer a few questions for you, and you'll keep coming back, and we'll if that doesn't, we'll answer them for you. I supposed to put it in the chat window, so you should be able to pick it up from there. Anything that you'd like to ask us?
What? So they're only planning for a short term, like 6 months, I guess.
Right.
Process. But why can't you just stay on Casedex? Why? I'm on a 50 milligram pill. Why? Because the study in New England Journal of Medicine is 150 milligrams, and they didn't do any Lupron or any of the other drugs. But I'm just not sure what the purpose of the Lupron is. I mean, I know it takes your testosterone away from you, but if the Casedex, since it's so small, it's 0.14, and I'm assuming it's coming down, and if it's still in the prostate bed area or in the pelvic area, and you are weakening it, why doesn't the radiation just work itself? So I'm not sure why the Lupron is a good idea, but I do subscribe to it's small and take a sledgehammer and kill the flea. I mean, I do subscribe to that thought process, but
so
yeah.
So the reason, as I understand it, that you take the Lupron is because it does a couple of things. It shrinks any remaining tumors that might exist, however small, and we may not see them. And it also makes the prostate cells more susceptible to the radiation. It weakens the prostate cells and it makes them more susceptible to the radiation. Now, and that's usually why they want you to be on the Lupron for a good few weeks before they start the radiation. In my case, I think it was I started the Lupron in late November, and I started my radiation in January.
Yeah.
Now, why you cannot do that? I don't know the New England Journal of Medicine study you're talking about, which gives high-dose Casedex with radiation rather than Lupron. Most of the studies that I've seen are with LHRH drugs. I mean, it's clear to me why the LHRH drugs work. If you don't have testosterone in your system, the cancer cells don't have anything to feed on. My guess is that by the same token, if you're taking high-dose Casedex, it also stops the testosterone in your body getting to those cells, and so the cells can't feed, and so exactly the same thing happens. They're weaker. It's a very good question. I don't know why Lupron is preferred, why an LHRH drug, an androgen deprivation drug, is preferred to an anti-androgen.
Yeah, because I think the only reason they gave me the Casedex is because of the flare-up.
That's right. That's why they
Yeah.
gave it. They're not using the Casedex
Right.
in the way that they used it evidently in this study that you read in New England Journal of Medicine.
Yeah. But then after I started reading, I'm like, well, why don't we just do that? Okay, but I appreciate the pamphlet here. How do I get that pamphlet? Oh, I see it. It's in there.
Okay. So, I don't know. Anybody on the call have any thoughts on?
Rick, this is Marty. I do. I understand. Our situations are very similar. I had surgery for 4+3. I had seminal vesicle, a lot of positive margins and all that good stuff. No lymph nodes. I've had 3 scans. Nothing picks up anything. My experience, I can comment on my experience with Lupron. I was scared to death of it like you seem to be.
Mm-hmm.
I took my 6th shot last week. I'm also scheduled only to have 6 shots unless it comes back. But anyway, and radiation. And my experience is I've not had the side effects that a lot of guys have and that are afraid of. I've actually lost 7 pounds since I started the Lupron. As Rick often writes about, exercise helped me. Hot flashes were manageable. It's not caused me to change anything that I was doing before the Lupron. So I guess I'm an example of every guy it responds differently, but it's not been the bear that I was afraid of.
How old are you?
I'm older than you. I'm sick. Right when I was 70 when I started it.
Oh, okay. Yeah.
I think the younger you are, the more likely you are to have side effects because your starting level of testosterone is going to be higher. One thing I would suggest you do before you get your first Lupron shot is measure your testosterone.
Yeah. Okay. Yeah, I'm surprised they did a battery of blood work, and I didn't see that. And I just did a
because a lot of them don't do it, and
yeah.
I personally think there are some very good reasons to do it.
I agree.
You know your baseline, and you know when you get back to your baseline.
Okay. Good point.
There are a lot of good reasons to do it. So if it were me, I'd be insisting that I want to have my testosterone measured before my first shot.
Yeah. Okay.
Anyone else? Because if not, I want to. We've got a few things to cover, and I also want to welcome some people to the call who haven't identified yet. But is there anything else before we move on from Charlie? Okay. All right. So let me tell you who I see on the call, and then you can identify. You can shout out your names to me if I haven't called your name. I know that we've got Jake, Paul Frieda, Marty Roder, Alfat, Albert Biasillo, Charlie Smith, Eric Bookbinder, Dan Schulist, I think, left, Jeff Ledoux.
Present.
Who else? Anyone else on the call?
Mike Tamales.
Hey, Mike.
Hey, Rick.
Dennis Correa. Hey, Dennis Correa. Anyone else?
Sylvester Mann.
Sylvester Mann. Jake, are you getting these? Jake, are you on top of this, man? I'm writing names down.
Yeah, I just wrote them down myself.
Okay.
I still don't know who caller number 6 is.
Okay. Well, we'll find out. And
who's
This is Eric. It might be me because I had to hang up and call in again.
Okay. No, we've got you. We're on top of you. Well, your name just came up when you spoke. So
Okay.
So we're good with you. Anyone else that hasn't identified and would like to? Okay. So let me just run down really quickly, because I know there are a couple of people that I know that that Albert we want to talk to, and I know we want to talk to Mike Tamales, because I got tipped off by his partner here in who's currently in California. And I know we want to talk to Marty Rodder because he sent me a note ahead of time. So let me just go down the rest of the people who haven't spoken yet. Jake, do you have anything you want to bring up?
Yeah, if we have time, I have a question about a possible side effect of Xtandi.
Okay. We can probably work that into the conversation with Mike Tamales.
Yeah, exactly.
There you go. See, I'm psychic here, Mr. Tamales. I know what's going on. You don't even have to open your mouth.
Yeah, you're pretty on top of it.
Paul Frieder, if he's with us, I probably have to unmute you and see. Hold on a minute, Paul. If no, Paul.
Yeah, I'm here.
Okay.
I'm here, but I don't have anything.
Okay, good. Marty, we'll come to you. Eric, anything for you?
No, not today.
Jeff, you gave us a quick update. Anything else you'd like some time for?
Yeah, I'm getting involved in some genomic testing.
Okay, so we'll try and hit on you. Mike Tamales will hit on you. Dennis, anything for you?
Yeah, Rick, if you could send me or give me some information about this castrate-resistant metastatic prostate cancer. We talked about it briefly before, and I think you said 3 successive increases in PSA. But my oncologists have told me before that it's not just the increase and it's the period of time and how much of an increase.
Let's come back to you if we've got the time, or we'll make the time, or we'll stay on a little longer, because we need to dig down and find out exactly what it is you need to know and why you need to know it, and then we can probably answer the questions. Not
okay.
Sure, but there's a good chance we can. All right. So, and Sylvester, anything for you tonight?
No, not tonight. Thank you.
Okay. And have I missed anybody? Okay, so let's kick off with Marty Rodder. Marty, give us the elevator speech on the issues around your what's the word I want? I just lost it. The
statin.
Well, no, it wasn't statin. The issues and the symptoms you're having are a result of your whole system slowing down, your metabolism. That's what I'm looking for. Your metabolic symptoms. That's what I was looking for. Give us a quick rundown on your metabolic symptoms and your question.
I'm not sure I know exactly what you mean by metabolic symptoms.
The issues regarding your cholesterol, your heart, etc.
Oh, okay. Excuse me. So as I mentioned, I had surgery, 17 months, came back, now finishing radiation tomorrow with Thursday and on Lupron. While all that was going on, I was diagnosed with high blood pressure. As a result of the high blood pressure workup, they had me do a heart scan that has shown moderate calcium buildup in my arteries. So
I did some brief research on what that means, and I saw that sometimes one of the treatments is to use a statin. So my question is which statin is best that I ought to steer the cardiologist to if possible?
And I know from just reading and speaking and hearing that the preferred statin is Crestor, and the reason for that, I think, is because it doesn't interact with certain other drugs that you may be taking during prostate cancer, but I can't remember which other drugs those are. Maybe someone else on the call can. That was the reason why Crestor is pushed rather than the other drugs. And I actually sent Marty some information on Crestor, and in that information, it actually refers to the fact that it can help with some of the heart-related issues that Marty is talking about. Anybody else on the call can help enlighten us on why Crestor is better and what they've been taking and why they've been taking it. Oh, and one other thing, Marty. Any man with recurrent or more than recurrent prostate cancer should really be on a statin. If for no other reason that we know that the cancer, as it gets smart, as it becomes castrate resistant, is able to reduce the cholesterol to its simplest elements, and cholesterol is made or built out of testosterone. So the cancer actually deconstructs the cholesterol for the testosterone, which it can feed on. So the lower level of cholesterol you have in your body, the better you are. So, you know, it's like another chicken soup. There are side effects from statins. Some people have worse than others, but they're not that great. And it's probably a drug most of us should be on if we're not already on it.
Yeah, I talked about that early on with the medical oncologist. My lipid panels are all well within normal limits, so he sort of poo-pooed it. That wasn't always the case, and I've been on it before. Diet and exercise seemed to bring it down before the prostate cancer showed up. Mm-hmm. But yeah, I've been thinking about that too, and that's a discussion I'm going to have with the cardiologist and then the med-onc.
Yeah. And that is essentially the essence of Zytiga. What Zytiga does, abiraterone, is it stops the cancer. It stops the prostate cells from deconstructing the cholesterol, from basically finding their own cholesterol, creating their own cholesterol. I forget now exactly how it works. I knew at one time, but that's the essence of Zytiga. But anybody else want to talk about statins they're on, or have any recommendations, or can help me remember what those interactions are that some statins may have and other statins do not?
Rick?
Yeah.
Rick, this is Jake.
Yes, go ahead.
You're right about Crestor. I think Snuffy Myers is a proponent of the Crestor. He's been talking about that for several years. Steve Bornstein's another one who uses it. I've been on atorvastatin or Lipitor for years, even before I found out I had cancer. And it may not be the best, but it's generic, it's cheap, and it doesn't interfere with any of the other medications that I'm on. Mm-hmm. What that's worth.
Mm-hmm. By the way, Crestor is now generic as well. I think it went generic at the very end of last year. So,
that's good news.
Yeah, I think in November or December of 2016 was when the Crestor went generic. So you might want to be looking into that if you're not on Crestor. Somebody else wanted to say something. Who was that?
Yeah, just me. This is Jeff. I am on atorvastatin, and with the research that I did, it said, 10 or 20, not so good. you get on to about a 40 milligram a day dose, and that's more effective. So that's where I am, 40 mgs a day.
Mm-hmm. Okay.
Are you taking that for its benefit for prostate cancer or because of high cholesterol?
That's because of the prostate cancer.
Okay. And which one were you on again? I'm sorry.
Lipitor or atorvastatin.
Oh, Lipitor. Yeah. Okay.
So Rick, this is Eric.
Yeah, go ahead, Eric.
I was told, for me, for my for my body, to never ever take a statin. My blood pressure is low, and statins lower your blood pressure. So that was a danger to me.
Okay. So again, I mean, everybody's different, and I'm sure that there's good reason for that. But I think
last time I went in, my blood pressure was 77/60.
That's right. I remember telling this. I just posted an article in the chat window, which I found about Lipitor versus Crestor. It's an old article, actually published on my birthday. I see here in 2011. But it does, and that it also mentions that it goes off. It goes off patent in 2016. But there's some good information in there. It talks about the doses and etc. Again, I think if it were me, I'd be asking for Crestor. I will try and do my homework to let you know what the interaction is. Steve probably knows, but he's not on the call today. I'd probably go for Crestor if I could. In the interest of time, I'm going to move on, Marty, if that's okay by you.
Sure. Looking at your title of your article you post, Rick, it says Lipitor and Crestor on a par. So, without reading the article itself, sounds like they're both equally beneficial.
Yeah, but I think the point is that the Crestor doesn't interact with certain drugs you might be taking, and that's why it's preferred.
Okay.
But I can't remember what those drugs are. That's what I say. I've got to do some research and try and remember. But I'm pretty certain the reason Crestor is preferred is because it doesn't have a certain interaction with other drugs you might be taking.
Okay. Well, we do need to keep you busy.
Okay. Yeah, just what I need. Careful, I may give out homework assignments here. So let's move on to Albert. You with us, Albert?
Yes, I am, Rick.
Hello, hello.
Finally figured out how to mute and unmute here. I don't know what it is.
Okay. Well, it's good to see you. Albert and I have been talking because Albert did some gene sequencing on a liver biopsy and came back with one clear mutation in TP53, which doesn't really have any actionable drug. But more than that, he found what they call a variant of unknown significance. And one of the things I did, and the variant of unknown significance was in the BRCA2 family. It was K3326. And Professor Bill, I see you sent me something, but I haven't had a chance to look at it. I asked Bill for his opinion on that. So, Bill, can you tell us what you know about K3326, if anything?
It's one of many, many possible mutations in the BRCA2 gene. But when a mutation is labeled as a variant of unknown significance, that simply means that it has never been associated with a case of cancer previously.
Mm-hmm.
But that doesn't mean that it's not associated or could never be associated with cancer. It just means that it hasn't popped up before as, in other words, there isn't a database of patients who have had cancer and that cancer has been associated with this specific mutation. So it could be actionable by a PARP inhibitor like olaparib.
Okay.
You won't know until you try. I don't know, how easy it's going to be to get your insurance company to buy that argument or even your physician. But I think that it's worth a try. It's just, it's simply a VUS is something that it's an unknown, and it could be something that's contributing to your cancer, and if it is, then a PARP inhibitor would probably do something.
Okay.
So tell us how you're doing, how you're doing yourself, how you're feeling, and what's going on with your local doc.
I've got a meeting with my local doc tomorrow. Just before the meeting, I got a call from the CVS, the pharmaceutical company, saying that my insurance company had denied the medication prescription. So I assume it was for the PARP inhibitor that it was denied. So I'll give my doc a call tomorrow and find out. But you'd also mentioned that the first go-around, they probably would deny it.
That's right.
So it's just something I've got to, we'll have to pursue. I'll see what he says. In terms of feeling, most of the fatigue and things like that are from the carboplatin that I had a month or two ago. And as my body's healing from that and the blood counts are going back up, I'm feeling better and better. So I'm still working, and the amount of sleep I need is a lot less now. So exercising a little more.
Good.
So I really, I can't, I'm not out doing a lot of aerobics or lifting weights or anything like that like before, but I really trace that to the carboplatin and not necessarily the cancer.
Okay.
Now, with the carboplatin, initially, and I forget what the number was, I think it was like 1,800, and the first 2 rounds of the carboplatin brought that down to about 500. And at that point, the next result that came in, the PSA was up again, and so it was decided by the doctor not to go ahead and use the carboplatin again. Now, he did say that, and I don't know, I'll tell you the truth, I don't know if I want to go to chemo or not, that there is a casaplatin or something like that, which wouldn't affect the platelet counts as much as the carboplatin did. That's about where I am right now. So kind of in limbo. No treatments for the past couple of months.
Bill, what thoughts do you have on how the doctor, the doctor's behind olaparib. He's already prescribed it. He wants to try it. Do you have any thoughts as to how to approach the insurance company?
Insurance company? Well, I think if I were writing the letter to the insurance company, I would very clearly point out, as I just indicated a few minutes ago, that that something that's labeled a variant of unknown significance is not necessarily not actionable, and that you find out pretty quickly if you try the drug whether or not it's going to work. So maybe Albert, how about I write down? How about I send you an email with what I think would be the most effective language that your oncologist could then use to make an appeal again to your insurance company. Would that be
that would
something
be
you're interested in?
excellent. Bill, I would
Okay.
appreciate it. Let me find you here, and I'll send you.
Bill has your email.
Recurrence, right?
Yeah.
Yes, that's correct.
And Bill has your email address because I copied him. And
okay.
Yeah. So
yes,
he has your email address. So thank you. Thanks a lot, Bill. And Bill, be sure to put your credentials. I know you usually do at the bottom so that when Albert goes and shows this, and the other thing, Albert, to tell your doc is that Bill has had tremendous success taking olaparib with a BRCA mutation. The one thing that is not clear to me, Bill, and maybe you can sort of help us peons with little knowledge understand, is what there's a BRCA2 gene and it mutates, but then there are other genes like this K3326 which are in the family of the BRCA2, and it's not clear to me how K3326 relates to BRCA2.
Okay, the K3326 is not a gene.
Oh.
That is information about where in the nucleotide sequence of the gene the mutation occurs.
Ah.
So, the gene is you can, imagine that it's a string of nucleotides that contains the information that encodes the BRCA2 protein.
Okay.
And when a mutation occurs, one of those nucleotides is altered, and the K3326 allows someone like me to know exactly where that alteration is.
I see. And so what you're saying is that we have never seen a BRCA2 with this particular mutation, K3326, impacting,
right?
But it doesn't. Now we've seen other mutations in BRCA2 associated with cancer, but we've never seen K3326 associated with a cancer.
Exactly.
Okay.
Right.
I got it.
But that doesn't mean that it might. So I have. When I went through genetic testing, in addition to the mutation in BRCA2, the sequencing identified mutations in 2 other genes, and they were both labeled as variants of unknown significance.
Mm-hmm.
So one of them, I'm pretty sure, is actually actionable. It's a gene called MLH1, because I know that mutation if you take a protein that contains that mutation and put it in a test tube, it no longer does what it's supposed to do.
Right. I know about MLH1 because that's what Trevor had, and they determined, and it's associated with Lynch syndrome, and and it's actionable by Keytruda.
Right, exactly. And so this is something that I'm planning to pursue in the future, is treatment with a drug that is actionable against that particular mutation.
Now,
but that's only because I know that it's been labeled as a VUS because of incomplete information.
Right.
And that it isn't necessarily that doesn't necessarily mean that it's not actionable. Does that have a...
Yeah, no, that's really helpful. To me, that's very, very helpful. Albert, a couple of things. One is, you should know that Dominic Arrested Soul went back and forth any number of times before he got his olaparib. So he did get it, but he really he had to fight for it. It took him about 4 weeks or so for them to approve it, but he got it. He was on the IBM policy, but I don't exactly know who the carrier was. I do know that olaparib is being approved off-label, and there are other people I know who have gotten it, and it just may take the effort. And I can reach out to a couple of people. If we start to hit problems, I can go back to some of the people I know who have olaparib.
Albert, what time is your appointment tomorrow?
I believe it's 3 o'clock. I've got to call and reconfirm, though.
And where are you? Eastern time? Okay, so I will get an email to you by, say, noon tomorrow that you can bring with you to your meeting.
Okay.
With language, you know, that you can use in an appeal letter. Okay.
All right. That would be excellent.
Okay, so we're going to move along, and we're going to hit on Mike Tamales and Jake together, because Mike, I understand that your doctor is talking to you about putting you on Xtandi. Is that right?
Yeah, he took me off the Zytiga and put me on Xtandi. Just switch over, he didn't titrate me off. He just switched me.
Mm-hmm.
And I was concerned about the steroids I was taking with it too. Yeah, if just stopping the steroids was a good idea, because I've been on them for a while, and it was hard to get an answer, but I stopped taking the steroids. I stopped taking the Zytiga, and he put me on Xtandi, and I guess we're going to go from there.
Let me just ask a question here. When was this, by the way?
Within the last couple weeks, I believe.
And did you stop the Xtandi? Did you stop the prednisone cold turkey?
Yeah, I stopped the cold turkey, and I called back and I asked to if that was right to do. I never got a return call. I went to their office. The nurse said that the doctor didn't get back to her on that yet. And so...
did you put it in writing to him as we discussed?
No, I didn't put it in writing.
Okay. How are you feeling? Are you feeling okay? I mean, how's your appetite?
It's about the usual.
Okay.
I'm not. Yeah, I'm still eating. But yeah, it's a little bit harder to eat.
Well, the first thing I do is I would put it in writing to him, as I said to you a couple of weeks ago when you came out of the appointment. Secondly, again, we don't give medical advice. I just know from experience that men who have stopped prednisone cold turkey have had significant problems, and that it says in prescribing prednisone with drugs like abiraterone, Zytiga, that you're supposed to titrate off of them. And I've actually seen what happens when you don't. So I think that for your own protection, you need to put that in writing to him.
I'm switching doctors.
Doesn't matter. You still need to put it in writing to him. Because God forbid you have a problem later on, you need to say, and when you put it in writing to him, you need to say, I called your office on this date, on that date, on the other date, and you didn't get back to me, so I'm just letting you know I'm off of this 2 weeks. It's a little bit more difficult for me to eat. I just want you to know. But you have to document it. It's important, Mike.
Okay.
All right? I know you're switching doctors. I understand that. You know, I said to Peter that Peter you should let the new doctor know that you stopped cold turkey. But anybody else on the call, it's not a good idea to stop prednisone cold turkey because the adrenals get used to the prednisone and it's a shock and they sometimes cannot adjust and there are all kinds of side effects. So you have to slow down off of the prednisone. You have to titrate off of it.
Well, I've been off of it for about a week now, and I seem to be doing okay.
Okay.
Around number 5, I stopped.
I mean, you know, you said 2 weeks a week. I don't know how long you've been off. If you've only been off a week, it may not, you know, I don't know if it's harder for you to eat. But I'm just telling you, there's not much more I can do. But I can just give you the benefit of having seen somebody who lost over 30 pounds because they didn't wean off and they didn't know what was going on in their system. They weren't happy. They lost all their appetite. They were miserable. And then we found out that they hadn't been titrated off of the prednisone. And I don't know what other side effects it has. You know, you could even talk to your GP about this. Your GP should be on top of it.
Yeah. I was talking with the pharmacist, and the pharmacist was saying as long as it's under 20 milligrams, there wasn't any need to titrate off. But that's what.
Okay. Okay. All right. I mean, I'm not a doctor, and I'm not giving you medical advice. I'm only telling you about what I've seen happen to people that didn't titrate off of it.
Yeah.
It's anecdotal. So.
And Peter's doctor said he wouldn't have done that either.
He wouldn't have titrated you off?
No, he wouldn't have stopped me cold turkey.
No, I don't think any doctor with their wits about them would have stopped you cold turkey. That's why you've got to put it in writing to him.
Okay.
Because if you've only been off a week, we don't exactly know what the side effects are just yet. It may not, you know, they may not kick in. And everybody's different, but at least you've put it in writing. Hopefully you have no side effects. Hopefully everything's going to be great for you. At the same time, we don't know. So just protect yourself.
Okay.
And you wanted to know about Xtandi. Jake, tell us what your question is, and maybe you can give Mike a little, a short primer on your experience with Xtandi.
Well, you know what? That's kind of hard to say. I don't really know. I've been on it for going on just about 2 months now, and I haven't noticed anything specific. I have, you know, aches and pains that kind of move around. I have numbness in my toe. But something that's happened just recently that and I don't know if it's related to Xtandi or not is well, I know pruritus, itching, is a side effect that affects approximately 3% of the people according to the literature. But I have a rash you know, I thought it was bites at first, but then I'm thinking it's a rash that might be an allergy kind of reaction. And I was just wondering if anyone on the call who's been on Xtandi has ever had that. Other than that, I can't mention any real side effects that I can definitely attribute to the Xtandi. In fact, my back pain has reduced a little bit. And I know my PSA has reduced from 15.5 to 3 point something in a month.
Right, which is great.
I'll find out what it goes down to next time on Thursday.
Right. Anybody else on the call that's
Has anybody had any experience
on Xtandi?
I was on it, Rick, and I was on it for about 9 months. I never had any side effects or anything.
Okay. So, Mike, Jake, I don't know that we can help you on this rash. You know, of course, goes without saying, you should alert your medical oncologist and see what she says.
Well, I'm going to see her on Thursday, and I'll ask her about it. I'm just concerned that if it's an allergy, then I'm going to swell up and not be able to breathe or whatever.
Right. So, you know, again, I think that you should talk to her about it. But I don't think I've ever heard anybody complain of a allergy from, you know, anecdotally from an allergy from enzalutamide, but I'm not certain. Mike, I think the biggest issue is what you've been facing, which is fatigue. You know, there's a lot of people take the Xtandi before they go to bed because it minimizes the fatigue. You take it once or twice a day? I can't remember. Once.
Once. You take 4 pills once a day.
Right. And
with or without food.
And do you take it? Do you take yours before you go to sleep, Jake?
Well, you know, I stay up till 2 or 3 in the morning, but I take it about 10 o'clock.
Okay.
And by the time I'm ready to go to bed, I sleep like a baby.
Okay. And Albert, what time of day did you used to take your Xtandi?
We can't hear you, Al.
Oh, sorry. I used to take mine before going to bed.
Okay.
So it helped me sleep, but the major concern was that I was working, and there was a certain percentage of individuals that ended up having seizures, and I wanted to make sure that didn't happen while I was driving or anything like that.
Yeah, it's very, very, very small, and when they actually look at the numbers, the people that had seizures actually had other contributing factors as well.
Okay.
That's something that I looked at just recently with Dr. Steve, because he's on Xtandi, and it was 0.6% of the people did, and of those, and I think which was like 3 people in the study, but of those people, 3 of them had mitigating factors, and there were reasons why they may have had the seizures that had nothing to do with the Xtandi.
Okay.
So I don't want to scare you with that. I think you've just got to, if you're interested, you've just got to look at the numbers, and there's good explanations why that happened. I think the important thing, Mike, though, is to take the pills before you go to sleep. Okay?
That's what I've been doing.
Good. All right. We've got to move on because it's already 5:05, and I've still got a couple more people that we need to hit up. Jeff and Dennis. Jeff, first of all, tell us what's on your mind.
Let's see. I had a meeting with my med-onc today, and also with the certified geneticist. She is requesting the panel from a more local company. It'll be about 3 weeks before I get the results of that for the genomic testing. My
Hold on a minute. So you understand that that is a germline test, correct? Did she explain the
Yes.
difference to you?
Yes.
Okay.
Looking at the BRCA2, BRCA1, and there's another one in there as well.
Right. But these are all for inherited cancers.
That's correct.
Okay. This is not looking at whether your tumor has made these genes, which it can and could do. That's a different test. That's the foundation medicine test we talk about.
Well, mine probably is inherited because my dad had it, and I've got it, and he had an aggressive adenocarcinoma.
Right. So
So
the question is, were there other cancers in your family?
actually, it doesn't appear so. He had 7 sisters. One of them died from a ruptured appendix. The rest of them have died in their 80s and 90s. No cancer noted there. On my mother's side, there's plenty of Alzheimer's disease, but no diagnosed cancers.
So, you know, again, we'll see what the test says, but that's not the type of history that typically you'll see with an inherited BRCA. You may do, but you know, if you had a lot of prostate cancer, of breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, other cancers in your family, you're more likely to see some inherited. So even if the tests come back negative, still doesn't mean that you're not going to respond to some of these immunotherapy drugs, because your tumor itself can be causing the mutations, and that's a different test. So I just wanted to be sure you're clear on that.
Very good. Yes, she did make that very clear.
Okay.
The ARV7 splice variant has not come back yet, and that's been out for a month to Johns Hopkins.
That doesn't sound right.
Waiting. Huh?
That doesn't sound right. Has anybody called them?
They started calling them today, believe it or not.
Hello.
We'll see what they can turn up.
I mean, I've seen that test usually gets turned around in about a week to 2 weeks. But
yeah, that's what they said originally.
Do you have the requisition form? I think I sent you the requisition form.
Yes, and I gave that to my med-onc, and they filled it out and they sent it in appropriately. It had been received appropriately.
Okay, hold on. I just asked you if you had the requisition form. There's a telephone number on that requisition form, and I've used that number, and the lab picks up.
Okay.
Okay, so if you call that number that's on the requisition form, you can find out from them what the heck's going on.
Okay, I'll do that. I'll do it tomorrow.
Yeah.
I'm not going to be doing much else tomorrow. We're having a hell of a snowstorm up here.
Oh, is that right?
Oh yeah, blizzard conditions.
You're caught in the middle of in the middle of that.
Yeah. The rest of it had to do with the PSA, and as I mentioned, it has come down just a little bit, and but down is good. We'll see what happens next month. I spoke about the Xofigo again, and it looks like that's back on the table. So they want to have bone scan, CAT scan before I have my next appointment next month. So
what about did you have any discussion about Provenge?
Provenge has already been done. That was finished in November.
Right. Okay, that's right. I forgot that.
So yeah, we have done that.
Okay. All right. I'm going to post the telephone numbers for you in the chat window right now. You're on the computer, right, or are you on the phone?
Yes, I am.
Okay.
I sure am.
All right. So I'll just send these to you. To Jeff Ledoux. There you go. There you go.
Okay, there it is.
All right.
Thank you.
You can follow up with them tomorrow and let us know what you find out.
I sure will.
All right.
Other than that, I'm pretty well set.
Okay. Any questions for anybody? Questions for any? Do you have any other questions, or can we move on? Whoop. I think we lost him.
No, I'm still here.
Oh, you're still there. Okay, so we'll move on if that's okay.
That's fine.
Okay, great. Dennis, are you still with us?
Yes, I am.
Good, 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 good. Tell it now. You were asking us about how do you know when you're castrate resistant,
That's correct.
and for what? Tell me the reason. Tell us the reason why you were asking the question.
Well, I guess it's a little conflicting between what I've gotten from my oncologists, both Dr. Singh and Dr. Amin that I have now, relative to my PSAs. You know, I started back in January of 2016. My highest was 17.1. And then it was, I started testosterone, the Permagon went down to 12.68 by April. And then the chemo, and then by June, it was down to 1.89. And July, 1.04. And then go forward to a month, the lowest point was 0.66 in August.
Mm-hmm.
That's when I finished my chemo. And then in October, it was 0.81. And then in November was 0.90. And my most recent one at the end of February this year is 0.98.
Mm-hmm.
So if you look at my lowest point, I guess at 0.6, I've had 3 successive increases.
Right.
Very small ones.
Right.
But, and my oncologist is telling me he's very, very pleased with my results. And when I've asked questions about, you know, the future and what might be and what will I be, he just kind of defers that off to, you know, we don't want to talk about that. We want to talk about right now. Just, you know, you're doing very well. Just enjoy your life and your days and keep doing what you're doing.
Right.
So that's what I'm doing. But you know, when I listen to you guys talking about 3 successive increases of any amount, any period of time, that means I'm cancer castrate resistant.
It does.
Mm-hmm.
But does it necessarily mean that I need to start something else right away?
Well,
that's my predicament.
Right.
Because my doc's telling me how good I'm doing, and
well,
so
here's the thing. I mean, these tests, the 0.6 was in, when did you say the point?
August.
August.
August was 0.66.
Right.
Last year.
Right. So, you know, from 8/16 through to 3/17 of this year, it's gone up about 50%. You know, there's a likelihood that you won't even double over 12 months. Now, the fact that you're castrate resistant is just that. It's a fact, because your PSA is going up whilst you're still on an LHRH drug. I forget what you're on. No, you're on Lupron.
Yeah, Lupron.
Yeah,
Lupron.
And you're still going up. When you intervene and what you intervene with, hard to say. You're not taking Casedex right now, are you?
No.
So
no.
I think most doctors would say, okay, we'll add Casedex, but if they add it now, if they wait until you get up to around 2 or 3, I mean, every doctor has their own style. But at some point in the next few months, yeah, they're going to change your treatment. They're going to add something. And hopefully that's going to, and the name of the game is to get the very most out of every possible phase of treatment. So the name of the game for you is, you know, if you're only moving up these very little amounts, the PSA is still, the tumor burden isn't increasing that much. At least it doesn't seem to be. What was your PSA? What's the highest PSA you've ever had? 20?
17.1 back in January of 2016.
Right. So, you know, you probably don't have a real high tumor burden in there, and I think the doctors are saying, well, let's just stretch this out. Yeah, we're going to add something. And what will they add, first of all? Probably the most simplest thing, which would be an anti-androgen, like Casedex. And they'll stretch that out. I mean, you know, there are doctors out there who would put you straight onto enzalutamide, which is a super fancy version of Casedex. At the same time, others would say, why go there? Let's hold that off and let's get the most we can out of each stage. So, you know, you take Casedex and hopefully that pushes it back down again, like somebody earlier in the call who said they started taking Casedex, Jeff, I think it was, who said started taking Casedex and his PSA's gone down again. And then when that stops working, you get off the Casedex because that may push it down. Because there is an effect where sometimes when you stop the Casedex, you can get a response. So you do these things slowly. So don't your doctor's right. I mean, I can see why he says he's happy because, you know, he's the chemo's doing a great job.
Yeah, that's what I wanted to hear you say, Rick.
You know, we know that you have cancer in your bones, and yet for a year you've managed to control that cancer.
Right.
And that's great. So, you know, if you lean on him and say, you know what, can we start the anti-androgen right now? He'll say, I'm sure he will say, yeah, if you want to. But he's trying to say to you, live in the moment. I like that. Now, which doctor was this one? This was not Dr. Singh?
Dr. Amin.
And he's here at U of A as well?
Yes.
Okay. I mean, you know, what he's saying is the same thing I'm going to say. Right now, all you should be thinking is go Cats. Right?
Yep.
Right?
Yep.
You know,
okay.
Enjoy the Wildcats beating up on North Dakota, and then whoever comes next after North Dakota, and enjoy your life. Have a game of golf, and let's talk, you know, next week or the week after or 2 weeks after, and you know, we'll take care of you. The one thing I do want to make sure that you just put in the back of your mind is when he does put you on the Casedex, to talk to him about getting a couple of shots to your chest of radiation, because that should stop you having any problems from gynecomastia. And a lot of guys don't think about it, and then they get sore nipples, and they suddenly find that they're developing breasts, and then they get the radiation. And it's best if you get it up front if you think you're going to be on these anti-androgens for any period of time.
And where is the radiation directed at?
Your chest. And it's
at the breast, at the chest.
Yeah, and it's just like 1 or 2 sessions. I don't know. Has anybody on the call gotten radiation to their chest?
Here I am again.
Okay.
Yes, I have. It was 2 shots of 600 microrads. Very small dose.
Right.
2 doses, and that was it.
Great. Thanks. So just make a note to talk to him about it. And you know, if you're up for it, I mean, if it were me, I would be getting it because I think it can avoid a lot of discomfort, and plus the fact that you don't want to be, you know, some men get upset because they're growing breasts and then they're embarrassed and they're this and they're that. So if you do this, it'll probably stop you. It'll help you, and you can do it later, but doing it later isn't as good as doing it up front.
Oh, okay.
Okay.
Sounds good. Yep.
All right, guys.
Thank you.
Yeah. We've run over quite a bit. I'm sorry. I was probably not watching the time, and we spent a lot of time with Dan Shoelist, and that's a kind of unusual situation that we had there, as most of you on the call realize, and I'm afraid that we offended him because he dropped off the call as soon as he got done speaking. So I will send him a note. Because I hope he does come back, and we want to support him, but we also don't want him talking to us about what to do next. All right. We will be posting this call, as always, probably within about 2 to 3 hours. That's about it.
Thanks, Rick. I'm out of here.
Okay. All right, guys.
Thank you, Rick.
I wish you
guys.
I wish you good luck.
Hey, Rick.
Storm.
Rick.
Yes.
Rick. Rick.
Yes.
Mike Kamal is here. Thank you very much for everything you do.
Oh, it's my pleasure, Mike. Mike, please send a little note to that doctor, telling him that you know, you're concerned about not titrating off. You've been off a week, and you're not eating as much as you were. Just let him know. I mean, hopefully you're not going to have any problems, but you just need to let him know.
Okay.
Okay?
I'll get on it.
Okay, good. Talk to you soon.
Thank you, Rick.
Bye.
Thank you, Rick.
My
okay.
Bye-bye.
Bye now.